So hello, thank you for the invitation. I would like to thank the organizing committee, Professor Rania Zaitoun and Dr. Fauzi in specific for the kind invitation. And I would like to tell you that I'm honored and it is a great pleasure for me to be here and to see what high quality and what level of speakers and organization you have. So congratulations, I need to congratulate you for that. So I'm going to talk about the use of ultrasound in cartilage and fibrocartilage. So ultrasound is, of course, an ideal way to image the synovial joints, but besides synovium, we can also image parts of the cartilage and fibrocartilage inside the joint. And the hyaline cartilage, of course, covers the articular surfaces and consists of water, basically, whereas fibrocartilage creates supporting structures like the meniscus, the palmar and plantar plates, the TFCC, and also is found in the attachment of tendons, in entheses, and ligaments. So let's start with fibrocartilage. The meniscus can be assessed using ultrasound. It looks like a hyperechoic triangular shape structure because of collagen fibers which reflect the sound. And when there is degeneration of the meniscus, you can see the meniscus as a hypoechoic inhomogeneous structure you might have cleavage tears, horizontal cleavage tears, as you can see here, and parameniscal cysts. But in all of those cases, you need to go on to do an MRI to be able to assess these further. The same accounts for TFCC, where in longitudinal views at the ulnar side, we can see the meniscus homologue as hyperechoic structure and the disc as a hypoechoic structure deep to the ulnar collateral ligament. But again, we need to perform an MRI, an MR arthrogram to be able to assess the injuries, although there is literature that says that we can do it with accuracy using ultrasound. Now, for volar plates and plantar plates, these are hyperechoic structures which separate the flexor tendons from the joints, and they reinforce the capsule. They are extrasynovial, so when there is synovitis inside the joint, it pushes the plantar plate and it can create weakening and tearing of the plantar plate. And ultrasound is a very good way to assess the plantar plates because we can see injuries at the plantar plates, like tears and retraction of the plantar plate or bony avulsions from the attachments of the plantar plate. The fibrocartilage at the entheses organ is a special kind of fibrocartilage. We can assess using ultrasound the enthesial fibrocartilage at the tendon bone junction at the area of the Achilles tendon, the sesamoid fibrocartilage at the deep part of the tendon, and the periosteal fibrocartilage. And when there is inflammation, macrophages can migrate from the synovium into the fibrocartilage, and there is also migration of new vessels from the bone into the fibrocartilage. And all of that can be assessed using ultrasound. We can see the presence of neovascularization and also irregularity, erosions, vascularization inside the erosions, and thickening of the fibrocartilage. Now let's move to the hyaline cartilage. The first reports about the use of ultrasound to image hyaline cartilage go back to 1984. But now this topic is expanding in the literature. And if you put cartilage and ultrasound, you come up with a lot of results in the PubMed. And the reason is because rheumatologists are so interested in cartilage, and because they like ultrasound, they produce a lot of literature. So the cartilage appears as an homogeneously echoic band because it is high in water and there are absence of internal acoustic interfaces, and this band is sharply defined. The superficial echogenic interface also is thinner, and it creates an artifact, which is because of the impedance mismatch between the cartilage, which is solid, and the fluid, which is water. And this artifact is only evident when the beam is 90 degrees to the surface of the cartilage. Using ultra-high frequency ultrasound, more than 24 megahertz, we can actually see this trilaminar pattern of the cartilage, and even we can see in the middle of the cartilage a hyperechoic area which looks like the trilaminar pattern which was first presented in pig joints in 1995. So we're moving towards ultrasound microscopy. When we want to image the cartilage, we need to have specific propositioning for good acoustic windows to expose the cartilage, and when there is synovitis of effusion, that makes the cartilage even more easy to be depicted because of differences in the acoustic impedance. But there are limitations, of course, in deep joints or in cases when cartilage cannot be exposed or when there are osteophytes. At the knee, we can see the normal trochlear cartilage by putting the knee in full flexion and creating axial images from the femoral sulcus into the trochlea, and we can see the cartilage very clearly. And we can also see the femoral condyle cartilage from the medial and lateral femoral cartilage with oblique transverse views. At the metacarpal head, we can assess the cartilage both in palmar and in the dorsal side by also creating a flexion of the metacarpal head in order to expose the cartilage and be able to see it, and by putting a lot of gel. Dynamic scanning is important for the metacarpal head cartilage because we need to reveal the metacarpal head cartilage by putting it in different degrees of flexion. And we can qualitatively evaluate the amount of disease in the cartilage, and we grade it as early damage when there is just heterogeneous increase of echogenicity and loss of sharpness, and late damage when there is asymmetrical thinning with irregularity of the surfaces, or when there is no cartilage at all. It seems that there is a very strong correlation between the ultrasound findings of cartilage damage and pain in osteoarthritis, and also between ultrasound findings and arthroscopy findings. But correlation is area dependent. It is higher for the sulcus of the knee and lower for the lateral condyle. There are also qualitative scores to assess the cartilage. There are 3, 5, and 6-point scales, both for osteoarthritis and for rheumatoid arthritis, like this 5-point scale. But the most commonly used one is the most simple one, which is the OMERAC 3-point scale. So we have grade 0, 1, and 2, normal cartilage, focal or partial loss, and diffuse or complete loss. Can we measure cartilage? It seems we can, with good reproducibility, both in adults, in JIA patients, in pediatric patients, especially in the area of trochlear cartilage. And the ultrasound measurements correlate with histology, but ultrasound underestimates the cartilage thickness compared to MRI. Elastography, ultrasound elastography, has been used to assess cartilage as well, and preliminary data show that abnormal femoral cartilage in osteoarthritis is stiffer than normal cartilage, but of course it's not in the clinical practice yet. Calcium-associated arthritis is a very good target for ultrasound, and we have crystals which deposit on cartilage and fibrocartilage. So basic calcium phosphate is associated with osteoarthritis, CPPD with pseudogout, and tophi with gout. So with basic calcium phosphate crystals, like hydroxyapatite, these are the most common, and we see them as clusters or balloons of hyperechoic bubbles inside the joint, which deposit inside the cartilage and fibrocartilage, as you can see here. And we need to dynamically assess the joint to see these crystals, because sometimes they float inside the joint. In gout, we expect to see the double contour sign. The crystals in gout precipitate over healing cartilage, and they create this double contour. This double contour is so characteristic for gout that in 2023, EULAR said that when we see this kind of feature, the double contour sign, synovial fluid analysis is not needed to confirm the diagnosis of gout. Ultrasound can. But we need to be sure that we have a good quality scan, and this double contour is independent of the angle of insonation and should be distinguished from the artifact which appears when the angle is 90 degrees, the cartilage interference sign. Here, when we move, we get rid of the cartilage, and we're able to see that this changes while moving, whereas double contour sign stays independent on the angle of insonation and movement. In CPPD, the calcific material is located inside the center of cartilage and fibrocartilage. This is also very characteristic. However, in some cases of CPPD, the crystals can go inside the fluid, the joint fluid, and then they can redeposit on the surface of the cartilage. And in that case, we might have together calcification in the center of the cartilage and fibrocartilage and on the surface of it. So we might have double contour, but only in 7% of cases. And if we have double contour sign, we need to have calcification inside the center as well. So, ultrasound for cartilage and fibrocartilage. Currently, ultrasound can be employed for diagnosis, monitoring, and research, basically in research in rheumatology, to depict the changes of cartilage and fibrocartilage, to grade them, and to measure them. However, there are a lot of limitations. The amount of cartilage which is visible is not the same in all joints, and there is a lot of operator and system variability. However, because rheumatologists are so interested in cartilage, and because they get the money to buy their own machines, and they have ultrasound machines, it is expected to increase. It is expected to have more ultrasound material on the cartilage. So we need, as radiologists, to be able to assess it as well, otherwise we will be overcome by the rheumatologists. Thank you for your attention, and I would like to take this opportunity to invite you to join ESSR, the European Society of Musculoskeletal Radiology. It is a European forum for education and research on musculoskeletal radiology. You can join as international members, and you can take advantage of all the educational material that we have in the website. We run webinars. We have an e-learning platform with a lot of videos and a lot of information about interventional procedures and diagnostic procedures. And you can take a diploma, which is called Diploma in Musculoskeletal Radiology, European diploma. And by taking that, you confirm that you are actually an MSK radiologist, and that will help you promote your skills. And with this, I would also like to invite you to our annual scientific meeting, which happens every June in a different place in Europe. In 2026, in June, it will be in Manchester in the UK. So I will heartily welcome you to come to Manchester and join us as international members. Thank you for your attention.